This is perfect timing.
Can you hear us?
Yes. Can you hear us?
Yeah, we're good. Okay, so maybe put the mic up to the computer.
Yeah.
Or hey, y'all can log on if y'all have a Zoom account. Y'all can log on. We're having some audio issues.
If you use the mic to just like tell us,
But you can like kind of put the mic towards the computer.
then we can use that. What I was saying, if I just run to my office, I can get like an extra speaker that will be a lot louder.
Or can we just mute this and speak into this?
Well, it needs to go through because like there's other people logged in.
Yeah, it's
Okay, so I think we just
we'll just
kind
talk
of
about it.
put it up and.
Okay.
Okay.
Just put this here.
Okay,
And I'll grab my external speaker. It'll just make it easier. It'll be more practical than this. I'll be right
Okay.
back, guys.
But I think we can get started.
Here, what? Here, I guess.
I'm having this feeling of just overwhelming joy at how much commitment there is to having clinical reason happen, that there is like so much pivoting and innovation and change and adaptation happening to make this work. So thank you all, everybody, particularly those of you at UNC, for troubleshooting this so that we can start the show.
There's sound coming over here too.
Awesome. Can y'all hear us?
Yeah.
Great.
And y'all, okay, I think we're good. Y'all can see your right there.
Awesome. So I'll quickly, my name's Mason Jeffries. I'm a third year internal medicine resident at UNC. And Anne-Marie kind of reached out wondering if I had a case. So the hardest part was not to find an interesting case because those are aplenty here at UNC, but it was to choose which among all of my stellar co-residents I would ask to chat with me. But we've got Erin Freed here, who's a third year internal medicine resident, Mike Rydberg as well. Both will be chiefs next year, and they're going to be helping kind of discuss the case and walk through some things. Are y'all ready for a one-liner?
That sounds absolutely perfect, Mason. Thank you so much for bringing a case and preparing it. In terms of the format structure, maybe Mike, maybe you and I can pair up together and take the first aliquot together. And then Robbie and Mason, I missed the name of Mike's co-discussant. Is it Aaron?
Aaron, yeah, that's right.
Aaron, awesome. And so maybe Aaron and Robbie, the two of you can pair up together. Mike, I will leave it open to you to discuss the first aliquot of the case. And if there's anything that I feel compelled to add, I can fill in. I can fill in after you. And if there is nothing to add, I get to say the three sweetest words in any case discussion, which is nothing to add, and then we can go ahead and go back to you, Mason, for the case. Does that sound okay?
Sounds great.
Sounds great.
Awesome.
All right, so your one-liner. This is a 54-year-old female with a past medical history notable for lupus who presents with 2 days of nausea, vomiting, and a fall. So a little more info. She's had diarrhea for 2 days, but when she came in, she noted some constipation. She's also had a little bit of a cough, some lightheadedness, and then a little more detail about her fall. She really couldn't give much information about it. She wonders if she had a head strike, really an unclear time down, and she's not really able to fully recount the details of her fall.
Okay, that sounds good. I think this is a nice place to start because she has a number of kind of broad complaints here that allow us to try to focus in on, starting here with nausea and vomiting, which is very nonspecific and could represent, I think, literally anything from any part of the body, which is always fun. So I think we're going to need to get a little more history on any other associated complaints, because we could have anything from an intracranial lesion to an intra-abdominal emergency or a toxic or metabolic problem here. I think the few key things I would focus in on are, one, the time, so 2 days. So this is a fairly acute process. It's not something that's been longstanding and going on. And then associated with cough. Now she also has lupus, which I'm assuming, or we're going to find out more, but raises the probability that she's on immunosuppressive medication. So I'm certainly worrying possibly about an infectious etiology leading to this, and I think we need to take a little bit more time digging into that. The next thing I'd want to know a little bit more about is the fall. And is that related to the nausea, vomiting, the cough, or is that a separate process? We didn't get a clear history of syncope, but we need to know more about that. Did the patient actually pass out? What symptoms led up to this fall? What happened afterward? And I think that's where I would start.
I can give you a little more information.
Sure. Yeah. No. I will just add to Mike. I think your assessment of where we're at in the case right now is very reflective of oftentimes where we are when we're evaluating patients who have a combination of non-specific chief concerns and a background medical history that potentially has some salient features, or at least some pieces of data that make us sit up a little bit more in our seats. And I think those things, being somebody who has a background history of lupus, we are overwhelmingly going to jump to two questions. Is this related to the lupus itself, or is this related to a complication of some of the other features that come with lupus? So for example, complications of immunosuppression, complications of disease progression, or complications of the actual treatment medicines that somebody does take. I think the challenge then, though, is that we have to map on this sort of initial structure of is this related to the disease? Is this related to the consequences of the disease, like immunosuppression, or is it related to a side effect of the meds? To map that on to these chief concerns is incredibly challenging at this point, because exactly as you said, Mike, constipation, lightheadedness, nausea, vomiting, even falls can be related to anything from a cold to cancer, and it's our job to try to figure out how exactly we are going to be able to start to draw a straight line to these things. And so I think at this point, there are a number of things that I'm tracking in terms of the possible organs that could be involved. For example, is the nausea and vomiting related to the gastrointestinal tract, or is it related to something like the neurologic system? Are the falls related to something like the cardiovascular system being disrupted, or are they related to something like the peripheral nervous system being disrupted? And I think at this point, where our hunt is going to be is less so about answering hypotheses, but more about generating hypotheses and thinking about how we can answer them going down the road. And so I think at this point, it's tough to start to draw straight lines, but I think that sort of general framework of, is this related to a flare of lupus? Is this related to some of the consequences of the treatment of lupus, such as immunosuppression, or is this going to be something that's completely unrelated to the background diagnosis of lupus? Here is about as far as I feel like I can take it as well at this point.
Awesome. Well, I'll try and fill in a little more information, so hopefully we can start to have a little more of a directed workup. So the her review system, she's had no fever, no chest pain, no belly pain, no skin changes, no new urinary symptoms. She's had no recent travel. When I ask her a little bit more about how she is feeling in general, she notes weak, and she has been having a little more difficulty ambulating with some dizziness over the past 2 days, as she's had nausea, vomiting, and kind of more diarrhea.
Great.
So should I move along to some past medical history, or do y'all want, you tell me.
Mason, this is Robbie. It's so nice to meet you all. Maybe you can give us, maybe we can round off the medical history, family history in that section before the exam, and then have my new friend Aaron reflect on that data.
Okay, perfect. So I'll tell you a little bit about her past medical history. Really the only condition that she has chronically is lupus, but unfortunately it's been a quite complicated course for her. She was diagnosed in 2013 after some workup for an unprovoked DVT, and she was found to have antiphospholipid antibody syndrome as well. And then a couple years down the line, she developed neuropathy. She had ulcerative cutaneous leukocytoclastic vasculitis, as well as pulmonary restrictive disease and serositis. And then a couple years later, she unfortunately developed lupus cerebritis, which was diagnosed after some neuropsychiatric changes, just a little bit more of a subacute process. And as well that year, she developed refractory ITP. So for her, the big thing had been trying to find a good medication regimen to help achieve disease control. At the time that I met her, she was on Plaquenil 200 twice a day. She was on prednisone, 10 milligrams daily. And she had been on rituximab, but that had recently been held due to a hospitalization in which she developed bacteremia.
And is she on CellCept, Mason, or no?
She is not. So she was on CellCept earlier in her course, but unfortunately, did not achieve disease control with that. And then she also had been on azathioprine, and as well, they had trialed her on one other medication, Cytoxan.
So currently just the Plaquenil and steroids.
Yes, and the Ritux she got like a couple months prior to coming to the hospital.
So I can take a stab at this. That was a pretty loaded.
Real quick.
Oh.
I'm so sorry. I think the case. This is Robbie, by the way. It's really nice to meet you all. Maybe you can tell us a little bit about yourself before you share more about the case. Is that okay?
Yeah, sure. That sounds good. So you want to start, Mike?
You go for it.
Okay. So my name's Aaron Freed. I think Mason had already mentioned, a third-year resident here at UNC. I went to medical school at Creighton University in Nebraska, and we'll be doing a chief year next year for the program. I guess as far as clinical interests, I do enjoy a lot of medical education, and I'm not sure what I'm going to go into at this point, but I'm sort of debating between hospital medicine and pulmonary critical care.
Amazing. A fellow teaching enthusiast. It's so nice to meet you.
Good to meet you.
And I think, Casey, do you want to just say a quick word too?
Oh.
No, she couldn't make it.
Okay.
Yeah,
No
that's
worries.
honestly my miscommunication.
Oh, that's okay. Totally.
So we have Mike instead.
Yes.
Yeah,
no,
I was the
absolutely.
clear second choice in that. But my name's Michael Rydberg. I'm originally from Minnesota, and then went to college down here in Carolina. Went to University of Chicago for med school, and love being here. I am going to be a chief, and then planning on pulmonary and critical care, which I like quite a bit, and married with a 7-month-old son.
Wow.
Ton of fun. So
Amazing. I don't think any future chief is allowed to say that you were second choice. Clearly, you're very highly regarded in your program. Awesome. Well, thank you both for joining us. It's a delight. It's always a pleasure for Jack and I and all the other VMR facilitators to meet new faces and get to know you. And I just want to be transparent. I deliberately interrupted you, Aaron, because I can tell the tension is building in this room. And I think the tension is building because this is a very complicated case, and all of us, we're trying to do something new here with this VMR collaboration and the mics and all that. It's all novel for every one of us. But I think there's an inherent joy in what we're doing and trying to understand this case and really break it down. And I don't want us to lose sight of that joy. So I'll hand the mic to you, Aaron, to really just enjoy breaking down this case and take it as far as you can with absolutely no pressure, because this is literally at this point an impossible case to solve. But where's your head at with it?
Sure. So I think, the first thing that kind of pops out hearing that next aliquot is that the review of systems is kind of not so helpful. This patient has some weakness and fatigue that's occurring in the setting of a couple days of what sounds like pretty profound nausea and vomiting. And so I wonder if, some of that may be related to the fact that this patient is probably dehydrated from all of this loss of bodily fluid. It doesn't help point us too much in the direction of localizing a specific process that might be happening that's causing her underlying presentation. And then moving on sort of to the history, this sounds like a patient who's had very complicated lupus with multi-system involvement in the past. And, lupus is a complicated disease because it can affect pretty much any organ system in the body. And I think the particularly important things that I picked out from that is this patient has a history of APLS, as well as ITP. And in the setting of neurologic symptoms, I always worry about something like a primary stroke. In somebody who has a history of clotting, I don't think we got the fact that this patient is on any anticoagulation. I don't know if it was a thrombotic event or a hemorrhagic event in the past, but that's certainly something that I'm keeping in the back of my mind. The fact that she's had ITP, I don't know if that's resolved, maybe recurrent, or never kind of went away, which would only kind of further heighten the risk for some sort of event. Also knowing that this patient has a history of lupus cerebritis, which I'm not sure I know or what the pathophysiology is behind like lupus cerebritis in a lot of cases, but I do think that that's something to keep in the differential for somebody who's having kind of neurologic symptoms of a fall and weakness, and who has a history of inflammation in the CNS. I guess those are some of my major thoughts. And then moving over to sort of the GI system, which is the primary complaint here, what's going on causing this nausea and vomiting to begin with? I think generalized inflammation, especially in somebody with a history of severe lupus, can lead to abdominal pain, discomfort, nausea, vomiting. But also wondering about different opportunistic infections, because we've answered our question that this patient is immunosuppressed and quite significantly so on chronic prednisone and Plaquenil, which kind of opens the bucket to a lot of different things. So I think that wraps up where I'm thinking right now.
That is one big brain, my friend. That is so many thoughts and so many different threads. And I love that essentially like your discussion focused on three key features. You're like the foreground is telling me neuro and GI, and the background is saying lupus plus immunosuppression. And you're taking those four pillars, brain, GI, neuro, neuro, GI, lupus, immunosuppression, and you're trying to explore those threads with what you know and connect them back together. And I think that's the way to go. At the end of the day, right now, this case is at a juncture where you're not trying to solve the problem. It's the equation and the problem representation here is too complex that your energy is appropriately invested in trying to simplify and understand the crux of the issue at hand. And so initially, as you just did, you're going to use terms that are very broad: lupus, immunosuppression, neuro, GI. And then over time, you'll clarify and make more and more progress on all those things, making sure that you don't lose anything along the way. So this might turn into a GI toxin plus brain syndrome in a patient with lupus, or it might turn into a peripheral neuropathy and an upper GI obstruction in a patient with lupus. The intuitive connection between neuro and GI is to invoke neuromuscular causes of motility issues and or toxins that are ingested through a GI tract that cause brain issues. I think that's the most common denominator, but that may not bear fruit here. My only piece of advice is remember that a patient with lupus is not immunized against diseases independent of lupus. So just because you have lupus and are immunosuppressed does not mean that you cannot have IBS or have an independent neurological disorder. So what happens when dominant conditions like lupus or HIV or vasculitis, what happens is the spotlight expands to include things that we otherwise wouldn't include, but does not shy away from alternative explanations that have nothing to do with lupus or immunosuppression. So I think that's key here. But again, your analysis is pristine, and I know that we'll continue to follow this thread: neuro, GI, lupus, immunosuppression, but then within that have a spotlight to, wait, this is neuro, GI in anyone who also happens to have lupus and immunosuppression. All right, Mason, I'll give the mic back to you.
Awesome. So I will add one thing, which was my fault. So she is fully anticoagulated on Xarelto. So that's important. So the aliquot number 3, for a physical exam, I'll start with some vital signs. So blood pressure is 113/74 with a heart rate of 98. Afebrile with a temp of 37.2. Respiratory rate is 19, and she's satting 99% on room air. In terms of an exam, she's alert and oriented to person and time, but not necessarily place. She doesn't look to be in acute distress. She just looks a little confused and tired. Otherwise, her exam is not super remarkable. Cardiovascularly, there's nothing jumping out, nor in the pulmonary system. Her belly exam, she has normoactive bowel sounds. She's non-tender and non-distended without any CVA tenderness, but she is a little uncomfortable, just in general, but not, nothing focal when you press on her belly. In terms of her neuro exam, she has somewhat slowed speech and she's unable to answer many questions. Her husband is with her and does a lot of the talking for her. She has some difficulty following instructions, but there's no focal deficits that are appreciated on exam. Her cranial nerves are intact. She has normal tone and strength. She is hyperreflexic on her right upper and lower extremities on the right side, and a little bit of, has some right-sided dysmetria, but that is all. So some initial labs. Her CBC, I also will give you a diff because I'm being generous. So she has a white count of 5.4. Her hemoglobin is 6.8. Her platelets are 251. And her ANC is normal. But one thing that's abnormal on her diff is she has 7% lymphocytes with a low ALC at 0.38. Her electrolytes are pretty unremarkable, except she does have an AKI. Her creatinine is 1.3, up from her baseline of 0.9. And her LFTs look good, aside from some hypoalbuminemia at 2.6. Her ESR is 26. She has a bland UA. She has an EKG that's unremarkable. And then to every internist's disdain, kind of, they did do a fecal occult and it is positive.
Am I taking this one?
Yeah, I guess so. Can Rydberg take it away?
No eosinophilia, right?
Yes, please, absolutely.
No eosinophilia, Dr. Kumpfer asked, but none of that.
Okay, well, I guess let's start with the exam, because that's interesting and not what I was expecting. Looking through it, I too was most focused on the abdominal and neuro exams, and I think the abdominal exam was fairly unrevealing, which is good, and that it sounds less like we have a primary abdominal problem, which she certainly could be at risk for. And then the neuro exam is very interesting. The first bit just sounded like she was going to be kind of non-specific encephalopathic with a bit of lack of orientation. But then, it sounds like she has some clear upper motor neuron signs with some hyperreflexia in the upper extremities, and then also some cerebellar signs with the dysmetria. So that's pretty interesting and definitely raises my concern that we need to, get some neuroimaging and further investigate the CNS, especially with the recent fall and her being on anticoagulation. So those are my initial thoughts about the exam. You want me to talk about the labs too, or should we pass those over to Aaron?
Either
Feel free
way.
to continue to talk about the labs.
Sounds good. The labs, I think a few interesting points. We don't have any leukocytosis pointing to an infectious process, but she's recently gotten Rtux, and Rtux lasts a long time. So I think that could partially explain the lymphopenia, although certainly could be other things as well, like numerous viral infections. You know, she's a bit anemic. Be nice to know her baseline. I'm sure it's not normal, but I doubt she lives in the high 6s. Not thrombocytopenic, which is nice to know and reassuring with their neuro and GI symptoms. Again, some of the rest of it would be nice to see in context with her baseline. You know, I don't know if the creatinine of 1.3 is a significant jump from where she lives, or is this essentially where she is with a little bit of dehydration in the past few days. Those are my initial thoughts.
And I'll hop in just to say her baseline hemoglobin is about 9. So this is a significant drop from where she lives. And her baseline creatinine is 0.9. So again, a significant jump.
Said she had a bland UA though, correct?
Mm-hmm.
Okay.
Mike, I think your analysis thus far with the data that we have, I think is absolutely fantastic, because what I appreciate is the fact that there's such an impressive amount of authenticity to where we are at in the case right now, right? We are still grappling with these two competing clinical with these sort of two prominent clinical manifestations, which center on the GI tract and on the neurological system. And we have gotten increased evidence that they're in addition to being a problem with the nervous system, there is an increased likelihood of there being a problem with the central nervous system based off of the hyperreflexia that you mentioned, and then grappling with the discordant data that we have around the GI tract, right? We have sort of very clear clinical symptoms that localize to the GI tract, but an exam that doesn't necessarily make the GI tract feel like the center of gravity. And this is an incredibly common challenge with abdominal symptoms where that we find ourselves in, right? The question is sort of how do I reconcile a fairly benign exam with symptoms that increase the probability of there being potentially severe pathology. Those symptoms being sort of persistent nausea, vomiting, and diarrhea, so much potentially to cause things like falls or at least a sensation of presyncope, as well as there potentially being a source of blood loss in the gastrointestinal tract. And I think another common place where we can see this develop clinically is in individuals who in individuals as they age, right? As somebody ages, the probability of there being a severe abdominal pathology increases, and the probability that that presents typically goes down. And one thing that is analogous to aging with abdominal pain is the presence of chronic immunosuppression. In other words, many of the things that we rely on, or that our body relies on to mount symptoms suggestive of underlying severe abdominal pathology, are related to a robust immune system. As somebody ages, that inflammatory response goes down, and so many of the symptoms of severe underlying intestinal or intra-abdominal pathology may fade. This is why somebody can be in their 70s or 80s and have an intra-abdominal abscess and not look particularly sick on exam. It's why somebody can be walking around and have acute mesenteric ischemia and a fairly benign exam finding, particularly in an elderly adult. And chronic steroid use does the same thing. The probability of an overt and very robust presentation of severe intra-abdominal pathology in somebody on chronic steroids is actually quite low. And so what we have to ask ourselves is, where do we set the threshold for feeling reassured that there isn't severe abdominal pathology going on? And I will say I am grappling with that question right now, given that we have so many features like the nausea, the vomiting, and the diarrhea that suggest this, in addition to the positive fecal occult blood test. Ignoring the potential difficulties with that test, right? We have anemia and something that suggests that there may be GI blood loss happening in somebody who has many reasons to potentially have abdominal pain or abdominal pathology given the background lupus. And so I think exactly as you said, right? Maybe not necessarily being completely terrified by the abdominal exam, but at the same time, I'm also not feeling particularly relieved about the potential for intra-abdominal pathology here, just given the overwhelming risk factors that we have in the history, the underlying steroid use, as well as the background history of lupus. Then the question becomes, well, what could some of that pathology be? And if we think about things that can cause inflammatory processes in the GI tract, we can go back to sort of our basic anatomical approach. This could be luminal problems related to an underlying gastroenteritis. This could be vascular problems related to ischemic disease that could be, for example, a byproduct of the known APLS as well as the known lupus, which can present with something like a mesenteric vasculitis. This could be related to potentially a process completely unrelated to the underlying lupus, which would again potentially be something like an infectious enteritis, but maybe not an opportunistic infection. Then we have to sort of say, okay, so how are we going to potentially work that up? And I think if there's one thing that I have learned from seeing patients who have reasons to not have an overt presentation is that you have to sort of get this RESPECT CT scan. I learned about the RESPECT CT scan from one of the attendings at the San Francisco VA, which is basically to respect the probability of there being severe pathology in somebody who has risk factors, regardless of what the underlying exam is. And so I think this is somebody where, even though there's no overt signs of peritonitis on exam, we sort of owe it to ourselves to further examine the intestinal hypothesis by getting something like a CT scan. And then we have to grapple similarly with the findings of the neurologic symptoms, where we potentially have an increased signal. I have very little to add to your analysis of the neuro exam. And I think just recognizing that there are signs of central nervous system dysfunction here, given what is the cerebral dysfunction accompanied by maybe some other motor symptoms as well. And that could be related to a focal process in the brain in somebody who has lupus and risk factors for brain ischemia, but also could be related to a more diffuse process, which could be related to an infection, particularly as Robbie had mentioned, right, the sort of brain to neurologic system infectious process, and also again related to a complication of the lupus. If we think about the tools we have at our disposal to further evaluate this, it comes down to really 4 tools. We have a CT scan, an MRI, a lumbar puncture, and an EEG. And how we prioritize that is probably going to depend on our concern for there being underlying CNS inflammation, right? That'll probably involve a CT scan first, plus or minus a lumbar puncture, plus or minus the MRI. And then if we see features of seizure activity, we might reach for the EEG. But I think that those first 3 tools, the CT scan, LP, and the MRI, are going to be the tools that we have to work with here for the neuro findings. And then the CT scan of the abdomen and pelvis, and then potentially endoscopic evaluation are going to be the tools that we have to work with for evaluating the neuro symptoms. But I think at this point, there are still more and more questions open as we try to decide where the center of gravity in this case is. And I still feel a lot of uncertainty about that, but I still think we have to carry the GI tract and the neurologic system together here until one of them demonstrates being a potential primary source of pathology. And we may find that both of these things are the center of gravity because it's related to the underlying process that is able to hit both of those systems. So I'll turn it back over to Mason to give us some more information in the case. But I want to see if Robbie or Aaron have anything else to add to where we are at in this at this point in the course.
Do we have hepatic function panel and a bilirubin that came with this?
We sure do, and they are normal. The only thing remarkable on the hepatic function panel is hypoalbuminemia, but
How low?
2.6. But her T-billy is normal. LFTs are normal. Nothing too exciting.
The reason I asked that is, with this acute drop in hemoglobin too, remembering that, and this positive fecal cold blood, which we luckily have, that there are a lot of causes of anemia that are unrelated to blood loss, and especially in somebody who has lupus, the risk of an autoimmune hemolytic anemia would be up there, but that seems to not be the case, which again kind of maybe weights the GI issue a little bit higher on my differential for potential inflammatory disease and blood loss.
And otherwise, did we get compliments?
We sure do. You're kind of taking us right into aliquot.
We can talk about further testing if you want that.
Yeah, I'd love to. It's honestly, this is a thrill for me because you guys, everything you're saying we're doing next is kind of exactly what they did. So just more validation that I trained with some good folks. So they did get an MRI brain with and without contrast, and that showed severe chronic microvascular ischemic disease. So essentially just progression of her chronic disease. Other things that they did The CT of the belly was unremarkable. There was no, gross issues or like acute abdomen or anything like that. They went ahead and got a CD4 count that was less than 35. They got HIV and hepatitis panels that were unremarkable. They got a COVID test, which was negative. They did do an LP, and it showed clear, colorless fluid with a glucose of 46, a protein of 34, and 1 nucleated cell, with a negative meningitis panel and cultures that are showing no growth. They got plasma CMV, PCR levels, and EBV levels in the plasma. Both were elevated. The CMV was 2,000 and the EBV was 7,000. The LDH was normal, and then they got complement levels, and actually they didn't get complement levels. I'm lying to you, but they did get, they got IgG, IgM, and IgA, and the IgG was elevated, IgM, IgA were normal. They also got an EGD. It showed patchy white plaques throughout the entire esophagus, so she was found to have candidiasis. And then they went ahead and scoped from below as well. And they found a single 5 centimeter deeply excavated clean-based ulcer at the hepatic flexure. And they took pathology. And no, I'll hold off on the pathology.
All right. Where to start with this aliquot? So we got a lot more data. Obviously, it's interesting, kind of the CT scan and the MRI, the things that we were sort of waiting on to help differentiate what's going on. We're both negative, which is reassuring, but also concerning at the same time. So moving to the LP, I totally agree with, was a very helpful thing. And I don't think it gives us that much. So I think the glucose was 40 something, which is, I think, in the normal range. The protein is not elevated, and there's no cells. So that's a pretty sterile CNS evaluation. So that's reassuring against some sort of meningitic process. Also now ruling out kind of an acute stroke or something. So I think we're definitely looking at something else leading to sort of her altered mentation. I do wonder, I don't think there were any big strokes noted, but sometimes you can get recrudescence of an old stroke that may present with kind of new neurologic symptoms, but that doesn't seem to be the case either here. And so that brings me back to wonder again, is this essentially a lupus cerebritis picture that is driving this, or some other kind of CNS process that we have yet to kind of figure out? Some of the other interesting findings are obviously the endoscopies that were done. So she has an invasive candidiasis, esophageal candidiasis, which can be seen, obviously in the setting of her immunosuppression. And she was never complaining of odynophagia or dysphagia. So I don't necessarily know that that's so much of a contributor to this picture, but more so something that just kind of we found incidentally. But the clean-based ulcer in the hepatic flexure is of interest. There are lots of things that can cause ulceration in the GI tract, but with the elevated CMV, EBV levels and immunocompromise, I certainly worry about like a disseminated CMV. I think that that could explain the ulcer, although what CMV actually does from an endoscopic evaluation perspective, I think it's more of multiple ulcers than a single ulcer, but I'm not sure about that. And then it also would not necessarily explain the CNS findings either, because we don't have evidence of kind of CMV in the brain or the CNS based on the LP. So that was a lot to kind of say. I'm not really sure what this aliquot moves us towards, but we've certainly ruled out a number of things, which I think is helpful in bringing us towards kind of more directed testing. I would be curious if they didn't get complements, but like a double-stranded DNA or something that might help us tell if her lupus is also flaring at this point. But I don't know that we have that. So that's where I would end.
My dear friend, I hope I can call you a friend, because honestly, you are an outstanding thinker, and I can tell a very good educator. And here's my evidence for that. You ended with the key question. And the key question here is this patient's lupus active or not? And the best test to make that conclusion is a rise in titer of the anti-DSD DNA if it was positive before. Some people are seronegative for that, as you know, because I think that's fundamentally the most important question now. That is one comment that you ended with, and I think that really highlights the pinnacle of your thinking. And I'll put that in conjunction with everything else you were saying. This case, I promise you, is compatible with numerous diagnoses. Whatever Mason tells us the answer to the case is, unless we're given more data to narrow the spotlight, there are many possibilities here. So the name of the game isn't so much now, as you're alluding to actually come up with the answer, because this problem has many potential solutions, but rather it's to try to understand the problem at a deeper level and ask yourselves, what tests are you going to obtain to actually make the filter of possibilities narrower and narrower and narrower till only one diagnosis is compatible, or if Hickham's dictum applies, multiple diagnoses. And here's why I think your key question of is the lupus active or not the fundamental question. I'm going to share the screen so you all will be able to see it on the big board behind you if you want to look behind you. But this finding here that we have in the case is striking. The amount of lymphopenia this person has is very abnormal. She has so few CD4 cells. And the reason in many cases it might not strike your fancy is transient lymphopenia from many infections makes us gloss over that abnormality. But we haven't found anything that raises the possibility of sepsis physiology. And here's why yours is so cool. Lupus is a common cause of lymphopenia, but if her lupus is not active, and that question is ambiguous here, we have to move to consider all these other things. And some of them were provided to us. By the way, this schema was made pre-COVID. So COVID is like basically this entire screen at this juncture, but it also fulfills the criteria of acute and transient COVID infection. But persistent lymphopenia, which we're getting in this case, may be the result of the steroids that she's taking, but I would argue 10 milligrams of prednisone is insufficient to definitively conclude that lymphopenia is steroidogenic, which is a term that this came up with, by the way, it doesn't exist. So what else should we consider? Lymphoma potentially of the GI tract we have to consider, and the possibility of these rare immunodeficiency syndromes, some of which are actually associated with lupus. So I think the lymphopenia is a key thread to follow here, but I want to throw in a crap ton of caution. Just because there's no inflammation does not mean there's no infection. Okay, to remember that forever. Just because, oh, sorry, I lost it. By the way, when you're about to make an emphatic point and you feel so passionately about it, make sure you're prepared, unlike me. So I'm going to do it again. Take it from scratch. If there is no inflammation, that does not mean there is no infection. Do we get it right this time? Yes, we did. Can you have meningitis without pleocytosis? Oh my God, yes. Cryptococcus is a notorious cause. Notorious. Guess what Cryptococcus is associated with? Lymphopenia. So is syphilis, so is HSV. So what are the possibilities here? Endless. What are the things that I'm really tracking closely to apply a stronger filter to get closer and closer to the diagnosis? Lymphopenia is hard to ignore here. And the key question is it lupus related or not lupus related? And I encourage you to continue your testing on the CSF. Don't let it just sit there because it's not inflamed, because many infections can actually show up in the CSF without a pleocytosis. That's where I'm at. And I'm curious what the next set of data will tell us.
All right. So for this next set of data, I will give you the pathology from the ulcer. So the pathology showed EBV positive B-cell lymphoproliferative disorder, suggestive of EBV diffuse large B-cell lymphoma. And we also have a PET, which just showed a hypermetabolic focus within the colon near the hepatic flexure. associated with subtle wall thickening and pericolonic fat stranding, which likely corresponds to the ulcer seen on recent colonoscopy / biopsy proven malignancy. Yeah, sorry. So that was kind of definitive. But everybody, I don't know. I mean, I feel like you guys had everything in line. Yeah, the other thing that they did hypothesize, it took a while for the pathology to come back. And so they were kind of weighing CMV colitis given the CMV like titer was high versus EB, something related to the EBV. So she had PTLD. So her neurosymptoms did show like subtle kind of chronic progression of disease, but I think the neurosymptoms were a little non-specific, and her husband was not a very good historian. So up throughout the case, kind of working it up, it was treated as new, even though it was kind of just subtle, kind of chronic progression. I am not sure if a crypto was sent of the CNS, and I would have to look back.
Certain opening pressure.
It didn't note the elevated or like the opening pressure, so can't comment.
How long had she been on Ritux for prior to this?
She was on Ritux for 2 years. So she would started on Ritux when she developed lupus cerebritis, and then stopped when she had basically hospitalizations 3 months in a row for bacteremia, fungemia.
Folks, I know we're out of time, but I cannot help but share a reflection medically about this case. But it's hard to, and I'll pass the mic to the crew and Jack to reflect on the entirety of this. But I want to leave you with this because I think it is important. It's very, very hard to make the diagnosis of cancer with blood testing. When we're trying to diagnose cancer, what we're trying to do is we're trying to get the tissue, basically. But I would say that there are some clues on blood testing that can help you make tremendous progress. And if you're looking for a solid tumor, a PSA, a beta-HCG, and an AFP in the right clinical context can help you make tremendous progress. But we were more in the world of liquid tumors, and what can help you clue in on the possibility of a liquid malignancy, of course, is a LDH that's really high or labs consistent with tumor lysis. But what's even more suggestive is extreme elevations of the SPEP or serum free light chains that are consistent with myeloma. And this is a tool that we use very infrequently that I think you all did used very well here. You used flow cytometry to pick up that CD4 cells were very, very low. And I think if I were to reflect on this case, I probably wouldn't have gotten that test. I honestly don't think I would have thought of it, but it was really, really a very powerful pivot in this case of flow that guides you towards lymphoma. So I think humbly recognize that I wouldn't have gotten that, but how profoundly it shaped the analysis of this case for me. And I know there's a lot more to reflect on the whole journey. So I'll pass the mic to Jack to tell us where he's at and say goodbye.
Thanks so much, Robbie. I think there are two predominant things that I would love to reflect on. One is gratitude to AMK, Mason, Mike, and Aaron for bringing this case and bringing their thought processes to the discussion today. I think this is one of this is an incredibly educational case, but also more importantly, an incredibly enjoyable case to get to think through. It was challenging. I will admit that I felt a mix of anxiety and stress at multiple junctures in this case due to the sheer difficulty of this analysis. And I think stepping back and asking sort of how can we take practical takeaways away from this case discussion to inform our practice going forward. I think one of the things that I'm reminding myself right now is that while it can be exhilarating and incredibly fun to get to make a final diagnosis correctly in a case like this, the more important thing for us as we try to take the skills that we build in this space into the practical space of on the front lines of patient care is not being able to necessarily say, I think that this is going to be PTLD related EBV, DLB, or EBV related DLBCL up front, but it's really knowing what tools we have at our disposal to advance towards the diagnosis. And I think knowing what tools we can use and when to deploy them is a really a very challenging thing that we often have to go through in general internal medicine and hospital medicine. And I think how we deploy those tools really comes down to the question of what is our threshold to get X test. And I think one of the things that I applaud all of the clinicians who took care of this patient for was to not settle for the absence of a diagnosis given the severity of symptoms. Because if you look through the workup, there is a relative paucity of clinical findings, at least in terms of the exam and a lot of the imaging findings before that colonoscopy came out. There's a relative paucity of findings that suggest a severe underlying pathology. We have a fairly benign abdominal exam. We have a neurologic exam that has some potentially chronic progressive changes. We have an abnormal differential count, but again, as we were saying, to sort of map the lymphopenia onto lupus is quite easy to do cognitively. And then we have a normal CT scan and many other of these unremarkable findings, but there was clearly enough suspicion for there being something within the GI tract to deploy that, what ended up being the diagnostic test of an endoscopy. And I think where we set thresholds is one of the ways that we can really become effective diagnosticians, right? To say that I think Scott put this in the chat, that the probability is high enough that this is a test that's worth getting, and using the background medical history, using some of these other features to say that there is a possibility or at least a strong suggestion that there is severe pathology in this case. And we have to find that, and we have to continue to hunt for that rather than closing on this is probably just a regular gastroenteritis. And I think asking ourselves, where do we set these thresholds in our day-to-day work, and how can we set these thresholds better so that we can use the tools at our disposal to effectively make a diagnosis is something that I'm going to continue to reflect on as a result of this case. But I just want to say that we're able to learn from this because a lot of brilliant clinicians said we need this endoscopy, we need to find what's happening here, because the CT scan, the labs, the exam, none of these things decrease the probability enough for us to feel comfortable with this patient going home. And I think going through that cognitive process is something that I think we owe to every patient that we get to take care of, but also something that can help us continue to grow. Even if again, we're not able to say this is lymphoma, we're able to say I need more information so I can figure out what this is, or at least what this potentially isn't here. I'll turn it back over to Mike and Aaron with any other reflections before we have Laura take us home with the teaching points today.
Yeah, this was a lot of fun, complicated case, but certainly I think it's a good experience to think through all of these cases and keep our minds open all the way to the final diagnosis. I know a lot of times it's easy to jump to kind of just wait for the pathology, but I think thinking in the interim about what this could be and what it might not be is something that we should all continue to practice. So thanks for having us. It's fun.
Yeah, thanks so much. We all really enjoyed it, and hopefully look forward to more of these in the future.
Yeah, thank you guys this was a great educational experience, and hopefully people learned from this. I certainly learned from this patient, and so and thank you guys for just continued stellar behavior as a co-resident.
Thank you.
Okay. Thank you so much. My heart is racing. This was so much fun. I spent most of the time just asking questions, as you can see in the teaching points. So let's start. We started with nausea and vomiting, which are non-specific symptoms, and we asked if it was GI or a neural disorder. And then we knew that she was immunosuppressed, so we had to think about an infection. And we had to ask ourselves, is this related to lupus or complications of the disease, such as progression of the disease or immunosuppression or treating medicines or side effects? And as for the lupus, it can affect any organ or system. So skin, musculoskeletal system, and pulmonary system are the primarily affected. But patients with CNS manifestations may experience headaches, depression, anxiety, seizures, stroke, or cognitive impairment. So it could be her case. And she had also the history of ITP. So we thought, could it be recurrent or a primary stroke or a clotting disorder? And then we thought that the main problem could be neuro and GI problems. So probably could be neuromuscular disease. And then we thought that her neuro symptoms were upper neuro syndrome symptoms. And so I brought them here. So it would be weakness and decreased muscle control and altered muscle tone and exaggerated deep tendon reflexes. And so the GI symptoms seem to be like the major symptoms. So it could be the cause of loss of water and blood. So it could possibly be related to immunosuppression, because Jack told us about the abdominal pathology and her underlying use of steroids or other risk factors that she had. And then it also could be luminal problems such as enteritis, or ischemic disease such as mesenteric vasculitis, or infectious enteritis, but not opportunistic. And then I brought some causes of GI ulceration, which could be steroids or H. pylori or alcohol use. And then Robbie told us about lymphopenia, which could be due to steroids or lupus, but then again, is it active or not? And then lymphoma of the GI tract or other causes. And he also told us that no inflammation doesn't mean no infection. Okay, so that's it. That's the end. Thank you so much, everyone. It was a blast, and I'll see you tomorrow.
Marvelous job, my friend. That was absolutely super. Thank you so much. Have a wonderful day, folks.